Welcome everybody to the Heart Health Lecture Series at the Center for Prevention of Cardiovascular Disease. It's a pleasure to have you all back after the summer hiatus. I hope you all had a good and happy and healthy summer. Today's topic is broken heart syndrome, and that is also about how emotional stress can affect your heart. Next slide. So I'm Dr. Dennis Goodman, and I'm a clinical professor in the Department of Medicine, Director of Integrative Medicine in the Leon H. Charney Division of Cardiology at our Center for Prevention of Cardiovascular Disease at the NYU Grossman School of Medicine, NYU Langone Health. And it's a real honor to be part of NYU Langone and the Grossman Medical School. And I'm really thrilled to be able to bring this lecture series to you that we've been going since 2015, and I like to thank Anya, like I always do, for such an incredible job that she does to make this happen. And of course, I'm so grateful to the speakers, and you're shortly going to hear about our speaker today, who is one of our treasured doctors and rock stars. Next slide. So just to do a little logistics, you can go to the Q&A button and ask questions during the talk, and I'll be fielding them. We have many questions have come in already online, so we'll be going through those, but I'll try to field some of the questions as well from the live audience. Next slide. So this is the way you stay connected to us. Many of you know this. There's a website. Take a picture of this with your phone. There's an email, there's an Instagram and Twitter. We like to hear from you, and this is a way that you can be in touch with us and find out what lectures are coming up and what's happening and what's available. Next slide. So we are very proud of our video lecture series, where we've now got really close to 100,000 hits. Many of our lectures have been recorded. This lecture will be recorded. So if you miss it or if you want to go back, you can go to this website, nyulangone.org/hearthealthlectures, and you'll find a link to all the lectures that have been recorded, and you can listen to them in your own time. And as I said, it's on YouTube. We've had close to 100,000 hits so far. So it's really a wonderful way for us to get the message out and for you to be able to listen to lectures that you'd like to hear or that you've missed. Next slide. So the upcoming lectures in this series are osteoporosis and heart health, why bone strength matters at every age. That's Wednesday, November 12th at 5 p.m. And then heart failure prevention made simple, what you need to know, on Tuesday, December 9th. We have experts in the field, and those will both be terrific lectures, and we look forward to seeing you there as well. Next slide. So as I said, the topic today is broken heart syndrome, how emotional stress affects your heart. Next slide. And it's my great honor and privilege to introduce Dr. Harmony Reynolds. She's on our faculty, she's a friend, and she's the professor of cardiology. She's the director of the Women's Cardiovascular Research. She's director of Cardiovascular Clinical Research Center at the Leon H. Charney Division of Cardiology in the Department of Medicine. Harmony Reynolds, Dr. Reynolds, Professor Reynolds is incredible, what we call triple threat. She's an incredible clinician, incredible researcher, and incredible teacher. Her interest in life has been women and heart disease in terms of her research, particularly women who have chest pain or heart attacks and then land up having open coronary arteries. In other words, they don't have a blockage. And she's done an enormous amount of research, and she's a world expert into that area. And it does link to our topic today of emotional chest pain and what can happen to women. The only award I want to just highlight for her, because it actually talks about who she is, which is a rock star. She got the Rock Star Research Award from the American Heart Association. So Dr. Reynolds, thank you so much. You're a very busy person. You do an amazing job. You're a world expert, and we are grateful that you've come to talk at our lecture series. You always come on when I ask you, and I'm very, very appreciative. Look forward to hearing your talk and listening to the answers to the questions, which I'm sure there'll be many.
Dr. Goodman, thank you so much for inviting me back. It's a real honor from a friend and colleague, and I know that this is always a lively group that asks a lot of questions, and I always enjoy these talks. Thanks so much for having me. Let me share my slides. You guys see those okay?
Yes.
Great. All right, so I have been asked to talk to you about broken heart syndrome, how emotional stress affects your heart. And we will cover today what makes broken heart syndrome different from other types of heart attacks, why it's called broken heart syndrome in the first place, what it looks like, what the causes are, and what the risks are. And then, of course, we'll have time for questions and answers. This is how I was trained to think about heart disease. And I like to think it wasn't that long ago, but it was long enough that I was trained to think that this is who it happens to, and this is what we're looking for. It happens to older men, pretty much exclusively. And what we're looking for when we think of heart disease is badly blocked arteries that are chock full of cholesterol plaque. Now, that's certainly a very important form of heart disease, but it's not the only form of heart disease. So now I'm a women's health researcher, so you know that I'm going to talk about something different. But what if we do this? What if we just put a woman's face on it? Does that work? And it does to an extent, because women also get plaque buildup, including the kind of severe plaque buildup that can cause a typical heart attack. But there's just so much more to women's heart disease, like the condition we're going to focus on today. But just to make sure that we know about when we talk about broken heart syndrome, which goes by a lot of different names. Broken heart syndrome is actually not my preferred name, as I'll explain. I think it's helpful to talk about what it isn't. So let's talk about traditional heart attack. The most common cause of heart muscle damage, and that's what we mean when we talk about heart attack as cardiologists, we're talking about heart muscle damage that is related to compromise in blood flow. And when that is due to blocked arteries that are due to cholesterol plaque, that's why they're blocked, that's a typical heart attack. And that blood flow can be compromised. It can be compromised over the long run, and then suddenly something changes and that artery is completely closed, usually with a blood clot in it. That's a typical heart attack. What does that look like? Typical heart attack, we would do an angiogram, usually in an emergency. And in this test, somebody is lying on an x-ray table, an x-ray camera is moving around them to take pictures, and the dark spider-like curly-looking things, those are the arteries. The red arrow is pointing to an artery that you see starts, and then it just completely stops where the arrowhead is. We can, through the same system, our interventional cardiologist in an emergency situation can go right in, put in a balloon, take out blood clots, and open up that artery, sometimes with a piece of metal mesh, a stent. And if you compare these two angiograms, I think you can appreciate that artery that was closed was actually quite a big artery and an important one. So that's what the men get. And women get it too. But there are additional types of heart disease that mostly happen to women. And as you heard from Dr. Goodman, that can be a range of different problems, one of which is open arteries. But first, let's talk about this thing, heart attack with narrowing that is due to a bruise inside the artery. In this case, not plaque buildup. The artery is narrowed, but it's narrowed because there's bleeding inside that artery. And that is called spontaneous coronary artery dissection. Like the problem we're really going to focus on today, this problem is 90% women, but the average age is 50. And in thinking of other types of heart disease that disproportionately impact women, there's the category of chest pain and heart attack that do not have severe artery narrowing from any cause. One form is broken heart syndrome or Takotsubo syndrome. And this is a problem that is really predominantly a problem of women. Men get it too, but not many. The average age here is about 65, so in a postmenopausal group. We call this broken heart syndrome because it is so commonly triggered by stress. Now, we think classically of emotional stress, and those emotional triggers are usually upsetting, hence the term broken heart. So it might be the death of a family member, a really bad argument, some other really bad news. But other triggers are actually happy things. There's a thing called happy heart syndrome. From the cardiology standpoint, it's the same, but we call it this when it's been triggered by something great, a celebration, a wedding, good news, winning the lottery. Those emotional triggers taken together, as it turns out, only make up about a quarter, this 27%, of presentations of broken heart syndrome. More, in fact, are triggered by a physical stress, and that's this dark blue, the 36%. Those physical triggers can be things that are like a severe illness, being in the hospital in the ICU with sepsis. Other types of heart attack can actually trigger this on top of it. It can be a number of different problems, but a physical stress. A range of medications can actually cause this, and all of them tend to have in common that they're related to an adrenaline-like pathway. And also extreme exercise can do this. So I've seen a number of cases of people who went and started a boot camp, for example. They weren't really ready for that. They didn't train up gradually. They just dove right into it, and they hadn't exercised in a long time. So I've seen Takotsubo syndrome in that situation as well. Some people have both, and you can imagine kind of a perfect storm. In fact, in thinking about the emotional triggers, it's a very interesting phenomenon with this, that sometimes Takotsubo syndrome happens in the moment. The person hears the bad news, for example, and they instantly get chest pain. But surprisingly, a lot of it is not instantaneous in that way, and instead may develop over days to weeks as a number of different stressors are smoldering in that person's life. And for some reason, it all just comes to a head on one day and not in the moment of hearing news. And you might imagine that that could happen when somebody has both a physical and an emotional stress. So that's at 8%. And then in 28%, there's no apparent trigger. So that's one reason that broken heart syndrome is not the first term that I reach for. But here I've got what's in a name. Broken heart syndrome, I think, is the most colorful name this problem goes by. But I do a research registry. I lead a research register related to this problem, and I've had a few people give me feedback that they don't love that name because it gives them a sense that they sort of did it to themselves, which of course is not true. So I've moved away from that term. There's the term apical ballooning cardiomyopathy. And here cardiomyopathy means that the heart muscle is not squeezing properly. Ballooning gives us a sense of how much the heart is malfunctioning. And apex because it's the tip of the heart that's most classically involved. So that's a very descriptive term. There's stress cardiomyopathy, sort of like broken heart syndrome, and this term takes into account the idea that you could have happy stresses too. But the original description of this was actually in the early 1990s in Japan, where it was first recognized, and the shape of the heart was described as being like a Takotsubo. And so the name is Takotsubo syndrome, and that's the name you'll mostly hear me use tonight. 1 to 2% of all heart attack events in women are due to Takotsubo syndrome. This is a Takotsubo. It means octopus trap in Japanese. And apparently this is a picture of an octopus trap. I can imagine the poor octopus getting stuck in there with all its tentacles outside. But here on the right is an echocardiogram, an ultrasound of the heart. And in this, you can imagine that this is like a heart that has its point at the top and its curvy parts at the bottom. That these are the upper chambers of the heart, the atria. These are the ventricles, the pumping chambers. And this main pumping chamber, the left ventricle, you can see has taken on a shape that is not normal. And it does look a little bit like a Takotsubo. To illustrate that further, I thought I'd show you a left ventricular angiogram. So this is just like I showed you a coronary angiogram before. The person's lying on an X-ray table, X-ray camera moving around. But in this case, we put the liquid contrast inside the beating heart so that you can see how well it's moving. Now let me play this, and you will see that this pumping chamber gets filled with liquid, and you can just imagine the heart squeezing that down and squeezing it out, right? I'll play it again. And here, when you get accustomed to looking at these, you can appreciate that all the different sections of the heart are doing their job very similarly. If you're not sure that you recognize that, let me show you the Takotsubo case, and I think you'll appreciate that it's very different. Here, this whole area of the heart is just not squeezing at all, and all that liquid contrast just gets sort of hung up there, and you can see it's very dark because it just does, that contrast doesn't move. And just this, what we call the base of the heart, the part that's closest to where the blood leaves, is still contracting. So I'm going to put them together. I think I can play them side by side. I hope you'll be able to tell the difference. So this one really looks like the octopus trap. Okay. What about Takotsubo syndrome looks like a traditional heart attack? Well, the symptoms are exactly the same. Heart attack symptoms typically involve chest discomfort or pain. I always say it doesn't have to be painful exactly. It might be uncomfortable, and it might not be right in the chest. It could be anywhere in the jaw, neck, shoulders, either arm, chest, back, upper stomach. But those symptoms, whether it's a traditional form of heart attack with a blocked artery, heart attack due to SCAD, heart attack with an open artery, or Takotsubo syndrome, to the patient, there is no way to tell the difference. It feels like a sudden onset of symptoms that don't feel right, sometimes with breathing trouble, nausea, vomiting, sweating, sometimes with the sense that something is wrong, although you don't really have to have that sense. So the symptoms can look identical. The electrocardiogram is clearly abnormal and may at a later stage, and I've shown an example here that's kind of a late stage, is distinguishable from traditional typical heart attack, but at an early stage, we as physicians can't tell the difference. And blood tests will be abnormal with elevation of a marker called troponin, which is a marker of heart damage. So that's similar between Takotsubo syndrome and typical heart attack. But there are many things that are different and make this syndrome unique. One is that it's not caused by a problem with blood flow from one heart artery in the way that the typical heart attack I showed you was. Often with Takotsubo syndrome, the heart arteries are not blocked in any major way. There may be minor plaque, there might be none, or there might be plaque in a small artery or an area that is not so all-encompassing in the way that the heart damages in the way that I showed you. The heart dysfunction in Takotsubo syndrome is often even more widespread than in typical heart attack. But the heart function returns to normal in the days to weeks after the Takotsubo syndrome event in survivors. And the damage is permanent in heart attack. And that is one of the things that has mystified the cardiology community in trying to understand why this dramatic presentation and then it all goes away. How does this happen? Well, there are different points of view on the causes of this problem. And I think it's a lot like it's a bunch of researchers using the techniques that they have and approaching the syndrome in one way. So I think it's a lot like blind people touching an elephant. So the people who think about stress say, okay, well, clearly this is set off in many cases by a stressor, either a physical stress or an emotional stress. Clearly stress is a big part of this, and it is. Others will say, well, the nervous system is not just about stress response. There's a whole balance to the autonomic nervous system, as I'll show you, the nervous system that controls the internal organs. So maybe it's just out of balance, and that sets the person up to be vulnerable. Somebody else says, well, if I think about blood flow, okay, traditional heart attack is caused by a blockage in an artery. But what if we think about all the small arteries that go to every little corner of the heart? Could the small arteries be implicated? And there's evidence for all of these. And then still others have said that when the heart is too thick, it can take on the wrong shape. And in a stressful situation, that might cause the whole Takotsubo syndrome. So these are probably all right. They may be some different mechanisms in different people. It could be that all these things come together, that one leads to another. There's a lot we don't understand. The first hypothesis, and it's still quite prevalent, is the adrenaline storm hypothesis. Stress raises adrenaline, and adrenaline and related hormones can be toxic to the heart. In fact, autopsy studies show that there's evidence of adrenaline toxicity in cases of Takotsubo syndrome when they look at under the microscope at the heart. But what doesn't fit with this is that not everybody has a stressor, and also medications that block the effects of adrenaline are not effective for prevention of this problem. So that is a key thing that doesn't make the adrenaline storm hypothesis work on its own. Let's talk again about the autonomic nervous system. We have the nervous system that controls our movements and how we feel, for example, how we feel our fingers. And then there's a part of the nervous system, the autonomic nervous system, that controls the function of the organs, the heart, the gastrointestinal system, etc. And the autonomic nervous system is this constant balance. We have the sympathetic branch. That's the one that makes adrenaline as we speak of it and is responsible for our fight or flight response. Everybody talks about it as if you're being chased by a tiger, you need to be able to run, and you don't need to think about it. You just run as a reflex, and you need your heart rate to get faster. You need your intestines to stop working so you can divert all your blood flow to your muscles. That's the idea of the sympathetic nervous system, instantaneous response when there's stress. The parasympathetic nervous system counterbalances this, and we sometimes call it rest and digest. So there are times when we need to rest. There are times when we need to stop moving because we need to digest. We need to conserve energy and control these other functions instead. That's the role of the parasympathetic nervous system. While the sympathetic nervous system will raise our heart rate, the parasympathetic nervous system will lower our heart rate. One raises blood pressure, one lowers blood pressure. You get the idea. Imbalance. So this system, I describe it as being that they counterbalance one another and being predominantly on one side or being on the other side. And when you see the seesaw, you might think in the same way. But in reality, these changes happen moment to moment so quickly that blood pressure can change in a minute. You know, if you've ever had the experience of having somebody check your blood pressure in a doctor's office and then a couple of minutes later you check again, your blood pressure is totally different. This is because these two systems are constantly changing, constantly in balance or out of balance, and impacting the function of our internal organs. It's thought that in Takotsubo syndrome, one of the problems may be, and some of our research supports this as well, that it's not just that the sympathetic nervous system gets overstimulated, perhaps by a stress or by a vulnerable tendency, but also that the parasympathetic nervous system, instead of kicking in right away and calming that, putting everything right in balance, there may be a lag. And the parasympathetic nervous system may come in too slowly or not adequately. And that might be the reason that there's a sympathetic predominance. What this boils down to is an inability to buffer stress, whether it's emotional stress or physical stress. I talked to you about the idea of the compromise of the small arteries. And here's the thinking behind that. On the left, you see an artery tree. This largest thing, this is the aorta, the largest artery of the body, and then it has the coronary arteries that feed the heart, and we see branches. And this may look a little bit to you like the angiogram I showed. And that's the level at which we can see large and medium arteries. These bigger branches, though, are responsible for only 5% of the control of blood flow to the heart. These are the arteries we see on standard testing. But there are smaller and smaller branches, right? It's just the arteries are just like a tree. They have the big trunk and the big branches, but then they have the smaller and smaller branches and the little twigs. And those are really important too in getting nutrition to the leaves. Same with the heart. The small arteries are harder to see, but it turns out that these control blood flow to a much greater degree. And sometimes they don't do their job. Their job is to wait until you need more blood to that heart and then open up and deliver more blood when you need it. And sometimes they don't do that job very well. Small artery disease is cause of chest pain. Cause of chest pain that disproportionately impacts women. And it can happen with no large artery problems at all. Small artery problems are more common among women than men, like Takotsubo syndrome. And there's some experimental evidence that when you do testing for small arteries in people who've had Takotsubo syndrome, they look like they're not doing their job. Now, why is that? Is it because of the imbalance in the autonomic nervous system? Is it the first problem? Hard to say. And then there is an entirely different problem, hypertrophic cardiomyopathy. And our research in collaboration, we have an expert hypertrophic cardiomyopathy group. They may have spoken at this lecture series, Dr. Sherrod, Dr. Becerra. And what they have found in working with me as well is that some people who have Takotsubo syndrome have an inherited heart problem that set them up for it. The idea of this hypertrophic cardiomyopathy is as follows. This is the left atrium, the top chamber of the heart that lets blood into the main pumping chamber. This is the left ventricle, the main pumping chamber that sends blood to the body. And then that goes out the aorta. And this here in this nice red color, that's the heart muscle. And in this person with hypertrophic cardiomyopathy, the heart muscle is a bit too thick. And also this valve that's like a door, keeping the blood moving in the right direction, that's the mitral valve. And it's not normal in people who have hypertrophic cardiomyopathy. It sits a little bit in the wrong zone. It's too close to where the blood is going out. It's supposed to just let blood in. And sometimes it's a bit too long, may get stretched out. So as the pressure builds, this mitral valve is getting in the way of letting blood out of the heart. And because the heart is thick, it's even more of a problem. It just gets very crowded in there. And that means that the blood can't get out nicely. It winds up going backward. And the pressure in this chamber of the heart just builds and builds and builds because the blood can't get out nicely. That pressure can become so high that it's too much for the heart to take, and it will simply malfunction. That seems to be a cause of Takotsubo syndrome in about 30% of people. More investigation on that ongoing. So that's a number of different mechanisms, and something that I didn't mention and would like to come back to with the adrenaline storm hypothesis is that it's very interesting on the molecular level, and just so that you have the right visual, I'll come back to that. When there's so much adrenaline, I told you that the heart responds by beating faster. It also responds by beating more strongly. again, so we can run from the tiger idea. But in some people, after, you can tell that when the heart is beating and it's been pushed, it's been whipped by all this extra adrenaline, it will, almost like a child who hears too much noise, it will react in a completely different way. We'll say, no, I will not beat extra hard anymore. I will stop. I will switch my response to adrenaline. And now I'm going to beat more weakly, because until you stop screaming at me, I'm not doing my job. Like a kid with their hands over their ears. That's called an isotype switch, and it happens at the level of the individual cell. But again, there's evidence for all of these in scientific studies. How do they interrelate remains to be determined. What are the risks after Takotsubo syndrome? Death in the hospital occurs at a rate not dissimilar from heart attack, 1 to 4 in 100. There is a shock state in 5 to 10%, and the shock state can be challenging for cardiologists to manage because there are two different flavors, and we need some extra testing in the moment to make sure that we're doing things right. But what about afterward? 1 in 10 will risk death or another major cardiovascular event every year after a Takotsubo syndrome event. And that is a pretty risky situation, even though the heart goes completely back to normal on our imaging test. The recurrence rate for having the same thing again is only about 2 in 100 per year, but multiple episodes definitely happen, and I've had patients who've had 3, 4, or even 5 of these. What about medication to potentially reduce the risk? Well, I wish that we had the kind of research studies that I have in other types of heart attack. We have internationally conducted tens of thousands of patients who get randomly assigned to receive a treatment or not receive a treatment, and then we feel that we know for sure if that treatment works. We don't have that in Takotsubo syndrome. Even though it's 1 to 2% of heart attacks, and a lot of heart attacks happen in the United States, it's a relatively young problem. It hasn't been recognized for all that long. 1990s to now is only 35 years, and in medicine, that's not so long. We just haven't had the type of research studies that we need to be certain how we can prevent bad problems after Takotsubo syndrome. But what we do have, and it's quite useful, is observational research. Doctors follow thousands of patients who've had the problem. Their medications are selected by their personal physician, and then we track whether those people who were selected for the medicine and who were not, which group does better. And in this case, with Takotsubo syndrome, this is from the INTERTAC registry, which is an international registry led out of Switzerland. It was found that people who were selected by their doctor to receive medicines in the ACE inhibitor or angiotensin receptor blocker group seemed to do better than people whose doctors didn't treat them with those medications. Now, scientifically, again, this is not perfect research. We can't be sure it's positive, but it's what we have, and it's strong enough that I generally use these medications in the patients I've seen after Takotsubo syndrome. You may wonder, what are ACE inhibitors? Those are the prils: ramipril, lisinopril, benazepril, enalapril. There are a lot of them. And the angiotensin receptor blockers all end in sartan: losartan, valsartan, irbesartan, candesartan, olmesartan, azulsartan. There are a bunch of those too. Which is better? We're not sure. It doesn't seem to matter. Now at the bottom, we see similar curves for beta blockers, and beta blockers are the classic adrenaline blocking medication. There are a couple of studies like this one that show that the lines that show you how likely is it to die after this Takotsubo event over time, here showing a year. Those lines are very close together, and the p-value shows us statistically they're just not different. There's no difference between these lines, and you can see that these two lines are that the ACE inhibitor and ARB, with and without, very different looking. So beta blockers don't seem to work in preventing the problem, which shows us that it's not all about adrenaline response. And in fact, in other studies, people who were already taking a beta blocker, and these are things that end in OL usually, metoprolol, carvedilol, nebivolol. I probably should use trade names for some of you, but these medicines are very commonly prescribed, and people who are taking them were no less likely to get Takotsubo syndrome than people who weren't taking them. So again, a lot of mysteries here. So much more research is needed. What are the causes? How do we put all this together in order to truly understand it? What is the best treatment? We need proper clinical trials. Is there a genetic cause? I've seen Takotsubo syndrome happen across families, mother-daughter pairs, for example. But can we pin down what that genetic cause is? Can we prevent it? After all, if you think about it, so many of us are exposed to stresses in our daily lives, right? And you don't know what's coming. So a surprise stress can feel like it hurts your heart, but for most of us, it does not cause a Takotsubo syndrome or heart event. So why in one person and not another, when that other person may have had what seems like a very similar stress? We need to understand how to prevent the problem. And how should we monitor people who had Takotsubo syndrome? As I said, the heart goes back to normal on our imaging tests. We see it's squeezing normally. It looks for all the world like a normal heart, which this never happens. But yet those patients are at increased risk. So how can we monitor patients? What kind of imaging tests should we use, or what other tests in order to see who's at risk for another heart event? So I hope that was a helpful overview. And now I know we have a number of questions, so let's get to them.
Gone here. Thank you so much. That was outstanding lecture, as expected. Brilliant as always. Can I just go back to one or two points during your lecture? One was you said there's like a happy stress. Are you saying that happy events can also be a risk factor for this?
They can.
So like something where there's a real celebration and people, what's going on over there? Is it a sudden surge of catecholamines, endorphins, neurotransmitters? That was
I wish I knew.
interesting.
I mean, it seems unfair. I started to think, well, it seems unfair if you're having a happy event to also have a heart attack, but surely it was unfair if you had something bad going on to have yet another bad thing. We don't know enough about which hormones, which transmitters, which chemicals that we make in the body in response to changes in our lives can cause our heart to malfunction. It's just fascinating.
I think it speaks for moderation, doesn't it? In everything.
Yeah, it does.
In terms of prevention, is there any data that shows that people that really work hard at lifestyle modification in terms of exercise, things that are going to increase the parasympathetic nervous system, yoga, meditation, are these people at less risk?
I wish I knew. And that is a study that we would like to do. We've got a device that works with deep breathing and helps people to breathe deeply and slowly in the way that people do with yoga. And we'd like to know if you do things like that will increase parasympathetic activity, could it reduce your risk? And, it's a challenging study to do because we don't know when the next big stress is coming along. And you don't really ask people. It's such an important question, and yet it's such a hard question to answer because how do we inventory people? Well, did you meditate? Were you somebody who relaxes? Do you do yoga? How often do you do this? So it makes a lot of sense to me that exercise, deep breathing, yoga, meditation would leave us less susceptible to this Takotsubo problem, but it's hard to prove.
Right. I think especially if there is a patient where there's an event and you think there's a significant stress, that post the event, you're going to work hard on those lifestyle modifications like we do for MI and unstable angina, where you are improving this parasympathetic nervous system. So I've got sorry, what did you say, Harmony?
I said I completely agree. And I was just going to add that we have an autonomic nervous system group right across the hall from where I am. And they've taught me also that one of the things that augments the parasympathetic nervous system, increases its activity, is actually prayer. And they say that across cultures around the world, when we pray, we slow our breathing. And they said, pay attention. And if you really pay attention, you'll notice it. So there are things like the rosary, things that are repetitive prayers make us breathe slowly. And they think that the reason religion has persisted, they have a very cold scientific view, but they say the reason religion has persisted is that it makes you healthier to breathe slowly in prayer.
Interesting. And same with meditation. It's all about breathing.
You bet.
One of our favorite participants who always asks me many questions. I'm going to shoot you 3 or 4, and you can just give very quick answers. The first one is Torsade de Pont. Are there arrhythmias associated with this that could be, the cause of death in that situation? Now, Torsade de Pont is often medication, but I mean, I'm sure we're also talking about ventricular arrhythmias.
Yes, heart rhythm problems can definitely complicate Takotsubo syndrome. And Torsade de Pont is, of course, a rhythm that that's abnormal and comes from the pumping chambers. Other types of ventricular tachycardia like that can happen with Takotsubo syndrome. So can heart rhythm problems that come from the top of the heart, like atrial fibrillation or other types of palpitation. They can often go together.
Okay. If someone's using an EpiPen for allergic reactions, is there any risk that this particular is going to be a sudden and adrenaline surge? Is any case reports about that?
Great question. Yes, epinephrine, including EpiPens, has been shown to cause this problem. But of course, you've got to take the EpiPen when you need it. And the stress of a severe allergic reaction is more likely to cause Takotsubo syndrome than the treatment of that severe allergic reaction.
Okay, calcium scoring, not going to help you really, one way or another.
Yeah, good point, because the calcium scoring is so important in prevention, but it's really all about finding that plaque buildup so that we can prevent the typical type of heart attack, which is the more common type, but it really seems to have no role in Takotsubo.
Okay. Mitral regurgitation, risk factor?
I mean, no, I don't think so.
You said IHSS, we spoke about IHSS and thickened heart where they get MR, but in itself, it's not a risk factor in terms of valvular heart disease.
No, it isn't.
Okay. Beta blockers, you've mentioned it. It's very ironic, isn't it? And in this case, where we think there's such an element of the sympathetic nervous system, haven't been able to show that they prevent it or afterwards are that helpful. Any explanation? There are obviously other factors, but you would think beta blockers would be a mainstay.
Yeah, I think that it's they block, but they don't block everything. Perhaps the surge of adrenaline and related chemicals is just so strong that the medication cannot block it. That's one possibility. Another possibility is that as long as you have enough of a parasympathetic restraint, you'll be fine. But without it, that's the key element, and the beta blockers are not part of it. Not sure. Okay.
This person asked about beta blocker increasing mortality, and are they a risk factor for heart attacks? Well, I think only if you stop them suddenly. I don't know if you want to comment on that, but beta blockers are really still a mainstay of our treatment for heart attacks. But what about is there any evidence that they increase the risk? My understanding is only if they stop suddenly.
I wonder if the questioner is referring to a very recently published clinical trial that has changed the way we view about beta blockers. And Dr. Goodman, of course, you're very familiar with this, so don't mind me while I explain it. This was a study in which people were randomly assigned. With heart attack, one of the key elements that determines risk is how strong the heart's function is afterwards. That heart function is characterized by a number we call the ejection fraction, which is quite simply the percentage of blood that's pushed out with every beat. It's supposed to be between 55 and 70%. Sometimes it's too low after a heart attack because there's been damage to the squeezing function of the heart. When the ejection fraction is low after a heart attack, beta blockers are critically important, and they're important long-term. But very recently, there was a study showing that if the heart function is preserved after a heart attack, the beta blockers didn't help. And that is really a sea change in how we're thinking about the use of these medications. And now I think what the questioner may be getting at is there was some media coverage of that study that highlighted in the subset of women in the study I'm just talking about, that recent one that said if the heart function is preserved, you don't seem to need a beta blocker. The women did worse with a beta blocker. And, statistically, I think from a pure science standpoint, we should not fixate on these men-women differences. In that study, like in so many studies, there were very few women enrolled. And that makes the precision of our understanding limited for women. So I don't believe that beta blockers are harmful, although technically that study did suggest it. But that's not something that I really believe. And I wonder if the questioner was getting at that. Hopefully we'll find out.
Okay. Let's go to our questions that have been sent in, and then we'll come back to some live questions. But brilliant. Thank you so much. Great answers. So what is the first step to take when you've gone through a stressful situation and need to check up on your heart to just see if you're at risk from this? As you said, it doesn't have to happen right away. It can be days or weeks afterwards.
Yeah, well, as far as a checkup, I definitely encourage talking to your doctor about what's stressing you, what physical feelings that you have around stress, because stress is an important risk factor. And one of the colleagues that I work with on stress research will say, we can't change what's going to happen to us, usually, right? These unexpected stresses, they happen, you can't control them. But what, through her work, she tries to control is that mind-body connection. And Takotsubo syndrome is just an extreme example of a mind-body connection. Sometimes it's good for us, sometimes it's bad. And her saying is what we do when we try to do what Dr. Goodman said, yoga, meditation, stress reduction techniques, is to not let that stress get to you physically. So I would say when you're in the moment in a stressful situation, take some deep breaths, try and get out of that situation. Hopefully it's something that you can distract yourself from, that you can take yourself out of for a few minutes, if that's possible. At least take a deep breath. But then when you need a checkup, go and talk to your doctor.
Which is a good idea anyway, because it's going to help you see whether you've got risks for coronary artery disease, hypertension, etc., smoking, etc. What about genetics? Is there any genetic testing that can be helpful?
I don't have any availability of genetic testing for this now, but this is the subject of a big research study that's being done in the United Kingdom and is recruiting patients now as they have Takotsubo syndrome, testing their DNA and going to follow them and figure out what the genetic determinants are. And we're hoping to partner with them through an international research grant to bring together our research registry, their research registry, and a number of other ones to try and get at that answer. Is it genetic? It definitely can happen in families sometimes.
It would be great to see if, test the children of someone who had it and see whether they're at increased risk. It would be so helpful in terms of prevention. Can broken heart syndrome occur in healthy adults younger than 65? Can it happen at any age? I think you covered that, but.
Again, it's typically a problem of postmenopausal women, but it happens to younger women as well.
You said the average age was 50. So
average age is probably closer to 65 here. I was thinking of coronary dissection, probably talking too fast.
Yes, thank you.
But yeah, I've definitely seen this in women in their 30s and 40s.
Can broken heart syndrome be intergenerational? I'm sure that's the question about genetics. So we discussed that. Next slide. I was previously diagnosed with broken heart syndrome and has been told it rarely reoccurs. Is this true? Why would it not happen again?
Why would it not happen again? I wish I understood. The reoccurrence rate in the largest study we have is about 2 in 100 per year. So every year, 98% of people don't get it again, which is wonderful. But why would it not happen again? And I've had this question posed to me by patients who've had Takotsubo syndrome before, and they say, that thing didn't seem like the biggest stress in my life. And then after that, or before that for that matter, this other thing felt way more stressful to me. Why did I get it then and not at these other times? Really interesting question. We don't have any answer.
Okay. Is it too late for a senior to begin to take measures to reduce the effects of a stressful life?
Oh, it's never too late. Absolutely. You should work on that today.
Never too late. And it's so important for people to realize, it doesn't matter how old you are, if you start, making changes, improving your lifestyle modification, it can make a big difference to the quality of the rest of your life. And we know that's well known. Next slide. How can I cope better with emotional stress while caring for an aging loved one? Do you know any resources to help?
I have been in that situation, and I definitely feel for that particular problem. NYU has an Alzheimer's disease and related dementias family support program. This is for caregivers of people who have dementia, and it doesn't have to be advanced dementia. It can just be some mild memory loss related to aging. And they're there really for you as a caregiver. They have activities where caregivers get together, either with their family member or sometimes without. They have counseling that you can access in groups or one-on-one. And they have a tremendous amount of resources online by linking with something called Caring Kind that can really help you to understand the challenges that you're facing and to know that you're not alone and to get some support.
Okay, thank you. Next slide. Is there a relationship between atrial fibrillation and this condition? It's interesting, we talk about holiday heart syndrome, where we know that it's related to increased alcohol consumption can actually cause atrial fibrillation. But how about atrial fib and Takotsubo?
To my knowledge, atrial fibrillation does not cause Takotsubo syndrome, but Takotsubo syndrome can certainly cause atrial fibrillation.
Thank you. Is there a hormonal reason for the greater incidence of broken heart syndrome in women?
Also a great question that I wish I had the answer to. So many unanswered questions in this problem. Clearly, there is a hormone relationship, right? It's 90% female cohort, and it typically happens postmenopausally. In research studies, it's hard to replicate that. There's one study in which they took female rats, took out their ovaries, and immobilized them on their back, these poor little rats, and that can model, those rats will get Takotsubo syndrome. But exactly what the pathways are as to why withdrawal of hormones may be related, we're not sure. And truly, if it were related to hormone withdrawal, you'd think that the classic age for this would be 50, when instead it's often 60s, 70s. So not clear how hormones are related, but they must be in something that's female predominant and happens mostly in the postmenopausal state.
It just shows you how much room there is for research in this area. Yeah. And you'll be coming back to give us a lot of these answers. Next slide. Would preemptively taking propranolol, a beta blocker, help prevent broken heart syndrome from occurring? I think we discussed that. There really isn't any evidence for that. How would you know if your heart is feeling stressed?
Well, sometimes people feel it. They notice their heart pumping faster or harder. Sometimes if I'm in a stressful situation and I just notice my heart, I think that's a signal to me to take a deep breath, see if I can get myself out of the situation, look out the window. But if it's Takotsubo, if it's gone all the way to being Takotsubo syndrome, then people generally have chest pain or other heart attack symptoms. And it's worth mentioning that not every stressful thing that causes chest pain is Takotsubo syndrome. This is really important, and I wish I had remembered to put it into the slide. So I'm glad this question came up. And people sometimes think, oh, I've been in this rough situation, and now I have chest pain. Must be Takotsubo syndrome. It's all going to go away. I'll just ride it out at home. That is a huge mistake because regular heart attack is also triggered by severe stress, and regular heart attack needs immediate treatment.
Just to amplify that, we know that 1 to 2 to 1 to 3 women die of cardiovascular disease, and they don't realize it. And so, women are so good about having mammograms, where there's a 1 in 8 chance of getting breast cancer or 1 in 16 of dying, but they don't get their hearts checked. And so this is just a plug to go and get that checkup and make sure that you're not at increased risk from heart disease, from cardiovascular disease and coronary artery disease. Not Takotsubo's, but actually coronary artery disease. Next slide. So let me just go quickly and see if I've got another question. I saw somebody ask a question here about, I think it's disappeared now. I just wanted to say, just to end it off, that I've had so many patients who have come to me with symptoms, cardiac symptoms, atypical chest pain and palpitations, and they're stress-related symptoms. And a lot of times the tests, they'll come back negative. We don't really find anything. And I go back to a story I had when I was a cardiologist in San Diego at Scripps, and one of my colleagues was a pulmonologist. He asked me if he would see his father. He was from an Italian family, a very close family. He said, my father's 80. He's the patriarch of our family. He's been having palpitations. They went to see all the doctors. They went to the hospital, and they told him they couldn't find anything except a few PVCs, but they weren't causing his problem, and that he's okay. And he was becoming more and more depressed. And would I see him? And I told him I'm happy to see him, but he'd have to come down from Seattle, and I didn't think it was to be worth his while to come all the way, but I'd look at the records. Anyway, he came down with about 10 or 12 people from his family. They were in my waiting room. They all came into my office, and I examined him, and I saw him, and I spoke to him, and I looked at his records, and all his tests were negative. There was nothing. And I said to him, is there something stressing you or something making you depressed? Because he looked depressed, and he said no. And then I came back in the office, and we were talking. His whole family was there. And I said, is there anything that could be upsetting him that's making him stressed? And one daughter said, can I speak to you outside? And she took me outside of his other office, and she said, Dr. Goodman, he hasn't been talking to his son for 6 months and it's killing him. And I went back into the office and I said, I think we have an answer as to why your heart's speaking to you. So I also call that, it's not the classical broken heart syndrome, but it's a painful heart syndrome and his heart's talking to him. And I said to them, the treatment here is not medication and not to tell him there's nothing wrong. I said, you go straight from here, take your dad to Vegas, that's where his son was, and tell his son he has to talk to him. And if he won't, I'll call him and tell him. And I did say this, that if he wants to see his father alive again, he should see him. Because if you don't take care of this, you'll have a real heart attack and then they'll find something. And 2 weeks later, I got a big case of wine in my office with a beautiful note from him that said, thank you so much for giving me back my life. I feel much better. My symptoms have gone and I've reunited with my son. And I just love that story because it shows you what impact we can have when people come with heart symptoms that we can't really find something going on. And that's why I love what you do, Harmony, because you're talking about helping people with open arteries or people that have stress-related syndromes, because you know they can have a really severe impact if we don't identify the stresses. So on that note, let's see if we've got 2 minutes here, and I just saw some questions come in here. I like to try to cover all the questions. Can CoQ10 decrease the risk of cause of heart attack, including QT prolongation? Well, I know a lot about supplements, and we don't have any evidence that CoQ10 can definitely reduce the cause of heart attacks, but we do have evidence that in some patients with heart failure and low ejection fractions, high doses of CoQ10, there was a study, the Symbio study, that really showed that there is benefit. Can radiation treatment for breast cancer cause a broken heart syndrome?
I would say yes, in the sense that it's a severe stress that people go through, right? A cancer diagnosis and the stress of cancer treatment. But the radiation, on a cellular level, it's not the radiation causing it. It's just one more stress. That's how I would view it.
Okay. Could you describe, if known, what shape the heart is presenting before an event? Or has such a BH event been witnessed? And if so, what has been gleaned from that? Are medications helpful? Interesting. I mean, please explain if there's any connection between HOCM and, BH.
Yeah, great point. So there have been some studies of people who are getting stress tests, for example. So their hearts are just under watch in the moment. And you can see the heart balloon right in front of your eyes. So it's normal until it isn't. But what Dr. Goodman is referring to is in the subset of people who truly have an inherited syndrome. Interestingly, it might not be so awful looking before. There could be some thickening, but in the people who have this problem, if they have severe thickening, those hearts are real thick, you don't wind up getting Takotsubo syndrome because when the pressure gets high, the heart's already ready to stand it. But sometimes the process hasn't gotten that advanced yet. And those people are the ones who are susceptible to abrupt rises in pressure. So they may have a little bit of heart thickening. The mitral valve might be a little bit long. It might be positioned a little bit too far to the front. There are these muscles called the papillary muscles that hold the valve in place, and they might be a little shifted in their location. Okay. But for most of the time, it's right before, heart's normal.
Last question, we've touched on it. Lifestyle recommendations for someone who's had Takotsubo. We touched on some of the stuff. Do you have a list? Do you focus on anything? We spoke about exercise, and I'm sure all the normal things that we say are so important for prevention, but I do think stress management would be very important.
I completely agree. Stress management, exercise, relaxation, deep breathing techniques, and of course, a healthy diet never hurt anybody.
Exactly. Thank you so much. Brilliant. And as usual, we really appreciate you doing amazing work. And I think you've realized we've got a lot of questions still unanswered, which you keep telling us. It'll be great when some of this research is done to get to the, closer to the bottom of what's going on in terms of causes. Thanks so much, Dr. Reynolds. And we'll look forward to seeing you again next year. Bye-bye. Thank you, everybody. We'll see you at our next lecture.